Uh, a very good evening to all the people who are attending this very interesting session uh, under the COS annual conference, which is going to be on refractive surgery. And we have very eminent speakers, and I'm sure that no matter who's watching, you'll find it very interesting and informative, and it'll help you in your practice and in your future practice also for the youngsters. And the chairpersons for this session is one is Padam Shri Dr. Mahipal Sachdev, and everybody knows him. He has held very eminent positions with the All India Ophthalmological Society, and he's been very prominent, and his lectures are in demand everywhere all over the country. And we are very thankful for him for agreeing to participate and give a lecture in this session. And he's the immediate past president of the AIOS. And along with that, we have Professor A.K. Jain, and everybody knows him. He's a very prominent figure in cornea, cataract, and refractive surgery, and he's a professor at the Advanced Eye Center in PGI Chandigarh. Um, I'm Dr. Amit, and I'm in the Advanced Eye Center, PGI Chandigarh, and I'll be moderating the session along with Dr. Chintan Malhotra, who is also my colleague in the cornea lens and refractive services in PGI. So I think without any further ado, we will proceed to the first talk by Dr. Mahipal, which will address the complications of refractive surgery. Over to you, sir.
Thank you very much, Amit. It's always a pleasure being part of the Chandigarh Ophthalmological Society, any symposium conference, and I always love to visit Chandigarh. And great to be in a session uh, filled with friends and relatives, I would say. Uh, I think really refractive surgery is one of the leading kind of surgeries that is happening on the eye, and over the past couple of years, it has become an essential part of the practice of any anterior segment surgeon. So I've been tasked to talk about complications of refractive surgery. And this is a video collection over the last several years that we have had. So why I'm stressing last several years is that complications are there, but they are not very, very common. So it takes really something which is in a refractive surgery, taking the bar higher. That is what things have improved upon, and we would not wish to have complications because we are working on eyes which are otherwise normal. So let us talk about the complications, and the complications of, I would say, refractive surgery would be essentially under overcorrection, induced astigmatism. There could be decentric. However, with the tracking coming on and the centration, things have improved much better than what it was. And the in making the flaps, the major complications that we are having, I don't think there is too much of complications as regards the laser process that it is now, but we still do have complications which are related to the flap which is there. Obviously, inflammation in the form of DLK, epithelial ingrowth and infection, and haze in PRK can be there. So just a very small single slider, I would say, on complications of PRK, because there is a surface ablation that is being done, whether it is surface ablation with the MMC or it is trans PRK, or whether we are doing an epilasic. There would be post-operative pain, and bandage contact lens soaked in veil or something like that can reduce it significantly. Epithelialization can be reduced, and there could be undercorrection, overcorrection. There could be corneal infiltrates, there could be sterile infiltrates, and there could be regression and haze. Those are the important things that are there. And haze is an important consideration which is there, which correlates with the ablation depth. Higher the ablation depth, so we normally don't do an ablation of more than -6 diopters, that is there. Oral contraceptive use, viral infections, ocular surface disease, etc., that is there, and we regularly use mitomycin C, that is there. Now, let me come on to the LASIK, and this would be basically a video-based presentation. This is flap fiascos, as I've termed it. This is the cornea. As we are seeing, we are marking it, though I have not used ink, but there's just a depression which you can see can help us. This is a 100 micron flap, and as you can see that it is going. And just watch here, you can see that the flap is sticking in the keratome, and when you lift up the keratome, you need not be jerky. That's something very, very important. You find that the flap has come on along with that, and you can see it's a free flap. So what do you do in case it's a free flap? You can see that there is an amputation which is here. What you have to do is that you should not lose the flap, which is very, very important. And then there were these marks which were there. The ink mark would have been better. You try to place it and try to align it. So you can get the marks, or you can see here that this is the cut edge and this is the cut edge. So you'll try to match these after trying this. So this is what is very important, that it's a complete flap. It is not a ragged, jagged flap. There is no buttonholing, etc. But what you see here is that you get, it is the stromal surface which is upside down. So what you will have to do is that you will have to just invert the flap in this particular case, and I'll just fast forward it, and then you can see that I'll try to match the edges which are there. Can you see these marks this is the mark, this is the mark, and this is something which is very, very important. I have done the laser, and then we have aligned the marks which are there. And all you have to do is that you have to wait for about 4 or 5 minutes instead of the normal 30 seconds to 60 seconds. You have to see that there are no striations in the flap, and you just kind of align it. You see those marks again, the indentation, you see it's coming well pretty much. And then the thing is pretty aligned. So what you have to do is to do a stria test. You depress it at the various places and see that the striations go on into the center of the cornea. And once you have done that, you will have to place a bandage contact lens in this particular case. And you can see that keeping the bandage contact lens for anywhere about 72 hours and removing it, you can see that post-operatively there's absolutely nothing that has seems to have gone wrong. But mind you, if the flap has been button rolled, it's very thin, etc., that a particular time you might have to discard the flap. Now let us just see this particular case, which who this case was lost was referred to me, and you can see that the person had tried to replace the flap and put a contact lens, but the obviously the patient was not having vision which was proper, and you can see that when we take the patient in the OR, this is the contact lens. As I remove the contact lens, you can see that the flap is coming along with it. But just watch the stromal surface. You can see that there is a depth which is deeper than the rest of the stroma, and you can see that here also. So it's a biplanar cut. Even though I asked the surgeon 2 3 times, but the surgeon denied. But according to me, what would have happened is that a microkeratome which was coming came, it got stuck, person went back, and then again ran the microkeratome at a different depth that was there. It went on to a different depth, and therefore you had a biplanar flap. The learning from this is that if there is a jam in the microkeratome, or there is a suction loss in the microkeratome, or you have reversed the microkeratome, then under those circumstances, you should not go back and rerun the microkeratome. That is very, very important. So we are trying everything to place the flap, because this is 72 hours late. It would stick on it because there is a lot of edema. So you go ahead and put the sutures, put a bandage contact lens, and you can see that this is what it is next day. But over 3 weeks, you can see that the flap is tending to melt. The sutures have given way. So we just amputated or removed the flap, and the cornea being very, very, I think it is one of the tissues which tends to regenerate the stroma, etc. And it really evens out over time. The patient came back with a good vision. Now let's come on to something which we can have. This is you have to differentiate between a central toxic keratopathy or a DLK. So this is a very severe case of a DLK, so you should not leave it. You will go ahead and lift the flap as you are seeing, and then you can see that there is already a melting that is happening. So what a DLK or a CTK does is that there is a hyperopic shift that happens in the patient, and there is a melt that happens. So you need to wash it. You can use moxifloxacillin here, or maybe a drop of steroids, and wash it very, very well, and keep the patient on intensive steroids. Just be very sure that the patient does not have any infection. Now let's come to another complication, that is post-LASIK ectasia, which is there. You have to identify the risk factors. What is more important, the most important is that you should have the risk factors seen before, so that you don't do in a patient who should not be done. And cross-linking followed by intacs, or an intacs and a cross-linking done together are two of the approaches. I always do a intacs along with a cross-linking in all the cases. So just to tell you, this is a tale of two eyes. This is a patient who is developing an ectasia, which you can see a patient who had LASIK done -2, -2.25. You can see that this is an ectasia where this is C3R has been done, but the patient has childbirth, is pregnant, and post-pregnancy you can see that there is an extension of the ectasia which is happening in this particular case. So a cross-linking in a post-LASIK ectasia, just a plain cross-linking, pregnancy, precipitating an increase. But this is the second eye where you can see that the OD was worse than the OS as regards the ectasia. In this particular case, this you can see is there is a for 37.7, 40.2, which is there, and this patient underwent an intacs with a cross-linking. You can see this is the intacs with a cross-linking, and you can see that the patient kept on improving. It's not because of pregnancy that the patient has improved, but what I'm trying to say is the patient kept on improving. Intacs takes a little while for the final improvement to come. And this patient, it's the same patient, two eyes, only cross-linking that was done in one eye did not allow the halting of the ectasia, but it is the intracorneal ring segment plus cross-linking. So that is the treatment of choice, which is very, very important. Now let's come to the femtosecond. In a femtosecond laser, the laser can stop at any particular time. I'll just fast forward because there are a lot of videos. You can see that this is a running of an intralaser. There is a power failure. The laser stops. So what you do is you go back again, get the thing working again with the same cone, with the same setting. You can see the OBL has disappeared, and with pocket off, you go ahead and just run the laser again. This can be done with any laser, not specifically. And you can see that this is the biplanar area, but this is different from a microkeratome because it goes in the same layer or the same depth. And you can see we lift the flap. In this particular case, I'm lifting it from down up. That is something very, very important, so that you don't have a lamellar dissection, and you can see that you can lift the flap and go ahead and do this. In case there is a dense corneal opacity, in that particular case, this is peripheral. You can see here, you can see that's a vertical breakthrough that will happen. And as we lift this, you can see at this particular point, we will have a slight rip in the flap. So because it is peripheral, I didn't bother about it, and I went ahead and did the, you can see is there's a peripheral. So if there is a corneal opacity, you can get a vertical gas breakthrough. We did the laser because it's peripheral, and we replaced it, and everything went fine. Very rarely you can have air bubbles coming in from the periphery going into this is a hyperopic correction. If you see in this particular, the flap is larger. What you do is that you can see that there's an air bubble. This comes very rarely. I've just had it twice in my entire career. And all you have to do is that the tracking will be off, or you wait for several hours for this bubble to disappear, and then the tracking will come. We just put the tracking off, and we can go ahead with the procedure. Flap stria is something very, very important. If you have a flap stria, these are macro stria. You have to de-anchor these stria, and it should be done best in the operation theater with the coaxial illumination so that you can see them well. Very important for you to remove the epithelium from top. It is only once you do remove the epithelium, because these are long-standing stria. You have to take care. You have to remove the flap from the undersurface, from the stroma, and you have to then swell the flap. Removing the epithelium, swelling the flap with hypotonic, obviously disinserting the flap from the stroma is something very, very important. Then you let it hydrate. As you can see, this is hypotonic. You can use two sponges running perpendicular to each other, and then you will try to take care of the stria. These strias will never, never, ever disappear on the table. But if you have removed the epithelium, put a bandage contact lens, and done the good amount of kind of pressing as you can, and then put a contact lens, you can see over time this is how the patient went on post-operatively, and there was a good outcome. Just to tell you, if we have to do a redo in a microkeratome, you can actually lift up the flap even 8 years, 10 years. This is 9 months. You can relift the flap. A femtoflap hyperopic may take a little more difficulty, but all you have to do is to identify the edge. And once you have identified the edge, you can go ahead in the same cleavage plane and you can relift the flap as you can see here. This is an epithelial ingrowth. You can see there is a track coming here, and this should not be left because this causes stromal melting. All you have to do in the epithelial ingrowth is that if it is progressing, you need to go ahead and just lift up the flap. This is how we lift up. If you press the edge, you can see the like a depression here, and that is where you go in and you can lift the flap. As you are seeing, we are lifting the flap here. And once we have lifted the flap, we will go ahead and you have to wash away the entire thing. You will use a hockey stick, you will use a aerosol sponge, you will then use mitomycin C, and you can use alcohol to actually see that the dead, see this is the track. This is what I'm telling you. This is the track through which it came. I'm using a hockey stick to see that all the epithelial cells have gone. You wash it very well. You use mitomycin C, you can use alcohol, and then we apply fibrin blue at the periphery. This is mitomycin C, as you can see. So either mitomycin C or alcohol, this is where it has gone. And then this as fibrin blue has been applied, and you will get good outcomes, which is there. I think there is a lecture on smile, but all that I will just show one or two videos on smile. Even smile has the complications. In this particular case, there is a suction loss. So this is a suction loss in the posterior aspect, and if you have a suction loss at the posterior aspect of the lenticule, then you have to go ahead and make it into a flap, as has been done at the same time, and go ahead and do an excimer. So it becomes from a smile to a femtolasic procedure. You could also do a PRK or call the patient at another time. Now in this particular case, what you will see is that this is the posterior part of the lenticule that is coming. You get the side cut, as you will see. This is the side cut that is happening. And then you start onto the anterior lenticule. You can see that there is a suction loss conjunctiva coming in. Ideally, I should stop, which I do stop in this particular case because I'm sure it is not going to get a good cut. You go ahead, hold it again, with the same cone. The machine will automatically take you to the level of the third position, that is the anterior to the lenticule, and you can see there is a slight decentration from where it was, but it really does not matter. It is in the same cleavage plane, and the procedure then can be continued in the same manner, as you can see, and there is absolutely no problem. You go into the same plane. That is the biggest advantage of the femto. You need to be careful. I don't use these straight forces, but you have these straight forces and just lift it. You can tear the side port which is there. Any debris which are, whether in a femto, whether it's a femtolasic or a smile, this is a lash which is there. If you will have a cold spot here, and then you will have dissection difficulties. As you can see, one should actually not continue with the procedure and abort, and you can see that there is a lot of difficulty here, and the flap gets torn, or a retained lenticule can be there. So how do you take care of a retained lenticule? You can do an OCT. If you have an intra-op OCT, you can go ahead and see whether you can see this is the folded lenticule which is there. You can use the OCT, or you can use triamcinolone, which is there. And we have also used and described the circle software. That means that you can go do the circle software and see the flap as to how it is. This is the triamcinolone which has been injected. You can easily make out the residual part of the lenticule, and that can be removed. You can see that the triamcinolone gives it a good strain, and then you can use it. So smile also has its challenges, though they are rare, but however they are manageable, and there is no loss of best corrected visual acuity in 99.9% of the cases if you are able to manage these complications. However, appropriate knowledge for the management is key. So refractive surgeries can have complications, but you should be a good corneal and a refractive surgeon to be able to handle these complications. That is where USP comes. Your USP comes that you will be able to protect the good vision that the patient is expecting after a refractive surgery. So with this, thank you very much. I have been able to show you a few videos, and challenges are what makes life interesting, and overcoming them is what makes it meaningful. Thank you very much for your kind attention. Thank you.
Thank you so much, sir, for that wonderful, wonderful collection of cases. And we have a lot of our fellows and MCH students listening in, and I'm sure they'll take back some lessons on what to do when they are in trouble. We'll move on to the next talk. I think we'll take some questions at the end. And I would invite Professor A.K. Jain to be speaking about phakic IOLs and how to handle unusual situations while implanting phakic IOLs. I think, yeah. So you need to unmute yourself.
Unmuted. Now share.
We can hear you, sir. Just share screen.
It's not. So screen is not getting shared.
Do you have it on your desktop?
Yeah,
Okay.
I'm on my desktop. EYECON. Share. Okay, let me try once again.
So you will get the choice of PowerPoint sharing or desktop one. You can go to the PowerPoint. So first open the PowerPoint.
Okay, can you see me?
Yes.
Now share screen.
Uh, if your presentation is open on the desktop, it will show you that Microsoft PowerPoint. Please
Sir,
open-
when you click on share screen, what are you seeing, sir?
It is showing blank this thing where it shows desktop one, whiteboard.
Click on
Microsoft.
desktop one. Click on desktop one.
Okay.
Then
Now it
click on
says
share.
open system preferences.
I think just do what it says, sir. I think it is not given permission.
Okay. Now it has open security and privacy.
Sir, I think this will take time. We can start with Himanshu's
Okay.
talk. And
Yes,
Okay.
we will call you, sir. We will
by
call.
that
Okay.
time, I think somebody can guide, sir.
Yes, yes. We
Yeah.
will call, sir.
All right.
Yeah. So now we'll go on to the talk by Dr. Himanshu Matadia. He's a very, very energetic corneal surgeon and refractive surgeon. And we always look forward to his talk. They are so clear, crisp, and they give such a nice message to all the people who are listening. So Himanshu is going to be talking about
Yeah. Hello.
intracorneal ring segments. Yeah,
Hello.
Himanshu, we can see your screen.
Yeah.
So please go ahead, Himanshu.
Thank you, Amit, and it's such wonderful to be here with you all. Only thing is, Dr. Mahipal said, we wish that we were together there, and we seriously miss each other, meeting each other. Going ahead with my topic, I do not have any financial disclosure here. The intracorneal ring
Yeah.
segment. The intracorneal ring segment, when we talk about, I'm not going to take this talk to any theoretical level. I'm just going to keep it very, very basic and very practical for newcomers. So when we talk about intracorneal ring segment, we should know what we are expecting, because we know that when you have keratoconus, the cross-linking is done for the stabilization of the cone. Whereas for the visual rehabilitation, there are other things like contact lens, intracorneal ring segments, phakic IOL, or the topo-guided PRK. So from intracorneal ring segment, we expect that it's going to stabilize, it's going to improve the vision or the quality of vision. Whereas to stabilize the cone, we combine the cross-linking. So usually we combine both of them, and it's done in the same sitting. Intracorneal ring segments are many, and of which the intacs or intracorneal ring segment, which is I'm going to talk about, is my preferred choice. But having said that, you can use whatever work in your hand. Now, intacs are available in two forms, and typically they're 150-degree arc, and there are different arc length also available. These are simple PMMS segments which go into the mid-periphery of the cornea and which flattens down the central cornea. The two common intacs ring is the normal intacs and severe keratoconus or intacs SK ring. Now the intacs SK ring has an oval cross segment and which is usually towards the visual axis area, which is 6 mm zone, between 6 to 7 mm, whereas hexagonal cross section of regular intacs is placed at 7 to 8 mm zone. How does it work? Well, it flattens the arc length, and that's how it shortens the arc length. That's how it flattens the central cornea. Please remember, it's not the physical stretching of the ring which flattens the cornea. It's actually increased bulk in the cornea which stretches the layers of the cornea. Hence, it's not actual stretching of a ring which actually can flatten the cornea. In that case, well, the cornea would end up in melting, and the ring would expand further. So how it works is a little different than intuitively we think. What are the goal of Intex treatment? Well, the most important goal is improvement in quality of vision. Please remember here, we are not referring to quantity of vision. It may not be very predictable in quantity of vision, but it certainly flattens down the cone, and hence it would surely improve the quality of vision. It changes the place of the cone, and the cornea becomes from hyperprolate to more towards prolate. The cases which are ideal are mild to moderate keratoconus, where the visual potential is decent, somewhere where the peripheral pachymetry, or in the 6 to 7 mm zone, pachymetry is more than 400. That's the mandatory part of it. Surgical technique wise, it's done under topical anesthesia, and the ring is placed at 70 to 75% depth of the place where we are placing the ring. So in SK ring, if you're placing between 6 to 7 mm zone, where there we are talking about 70 to 75% depth of that place. Now let's start. How do we place the ring? Now that's the first thing which comes to our mind, that can you guide us? How do we go? So let's go step by step. First step, we require certain thing like manifest refraction or corneal topographic values. The refraction, we have to remember, we only pay attention to refraction where the vision is better than 6/12. Anything less than that, the reliability of refraction can be pretty doubtful. When the cylindrical axis of your refraction does not match with topographic axis by, say, 15 degree, I wouldn't pay too much attention to the refraction. In corneal topography, you should preferably have an elevation-based topographer or tomographers, which can give you axial topography, posterior elevation map, as well as pachymetric map. Now, step 2 is identifying the location of the cone. So first, we identify the keratoconus. The second, we identify the cone, whether the cone is centered cone or cone is decentered. By that, what we mean is the 50% of the cone is within 3 mm zone, we call it centered. If 50% of the cone is away from the central 3 mm zone, we call it decentered. In case of centered cone, we use symmetric rings. In case of decentered cone, we use asymmetric ring. Step 3 is identifying the incision of the intakes. Now, first and foremost, I follow something called intuitive method. Second method, where you draw a line from the posterior elevation map, center of the posterior elevation map, to the center of the cornea or the corneal apex. You draw a line which is actually flat axis, and a perpendicular to that becomes steep axis. Remember, in keratoconus, always your cone is towards your flat axis, or it's on one side of your steep axis, right? There are certain verifying methods or verifiers for identifying axis. One of them is the steep axis of your subjective acceptance. Remember, we know that steep axis is always plus cylinder form. So always convert your refraction into plus cylinder form, and whatever is axis is the steep axis. And the another one is steep axis on your corneal topography, right? Now let's see, if we have a cone like this thing, intuitively, what do you think? Where would you want to push the cone from? Well, of course, by putting a ring, I want to push the cone from below. And that's what my intuitive method. Now, intuitive method helps me to grossly identify where the ring should be, whereas my definitive method, like using the tomography, it helps me to place more accurate placement of my incision. So I draw a line from the posterior elevation to the center of the cornea, which is flat axis. A perpendicular to that is the steep axis. Wherever it cuts, that's my axis. And if you look at the verifiers, well, we convert the refraction into plus cylinder form. The axis here is 10 degree, which is like same as my topographic axis, which is absolutely fine. So this was deciding about the incision. Where would you put the incision? And usually that's the steep axis. Step 4 comes, which is deciding the thickness of the segment. There are nomograms which are given by the company, but please remember, this method cannot be very accurate. You cannot pinpoint the outcome here, but you still need to have a starting point where the nomograms by company come into picture. These are the nomogram for the regular ring. And the problem with any intracorneal ring is it underperforms than overperforms. So rather than that, I would rather choose my SK ring or severe keratoconus ring. So based on the spherical power, when you convert into the plus cylinder form, whatever you have different ring segments. And in case of asymmetric cone, based on the cylindrical power itself, you decide the ring segment. The place where the cone is, where you want to push it from, you put thicker segment. The opposite side to balance is always a thinner segment, which is 0.21 millimeter, which is standard. Let's take an example. Now let's see somebody with -4 and -4 cylinder. The vision is not so great. But whether this cone is centered or not, well, it's centered cone. That means we are going to use symmetric rings. Now let's again see, where would you want to push it from? It looks like it's a little bit on this side, so I would rather want to push it from that side. And that's my intuitive way to decide that my rings would somewhere be there. And if you look at your definitive method, we know that steep axis lies somewhere where it shows there. Now let's see where we convert into the verifiers, where we convert into plus cylinder form. And in that, the steep axis is 130 degree, which is quite similar to what we are getting in our corneal topography also. So our incision should be at 130 degree. Symmetric rings we should be putting there. The depth, well, 70 to 75% depth at the level where we have the ring, or 6 to 7 millimeter zone. Which size ring? Well, based on what we saw there, that it's somewhere around steep, like -8 if we calculate the plus cylinder form. So I need rings which are on the higher side or higher thickness. And that's why I'm putting 0.45 SK ring. And that's what, this is the pre-op and this is the post-op picture. And you can see it flattens down the cornea as well as improves the quality of vision. Coming with the second example, how does it look? Well, it looks decentered cone to me. That means I have to put asymmetric ring here. I want to push the cone from there, so thicker segment would come there. When I want to put ring, in case of asymmetric ring, I go by cylindrical power. And here, if we are looking at the cylindrical power, which is somewhere around -4, we are putting a ring which is 0.45 SK ring, and opposite side to balance. Now, if we have like Dr. Mahipal was talking, post-LASIK ectasia, the best indication for intracorneal ring is post-LASIK ectasia. So I would certainly like to use intracorneal ring for something like this kind of post-LASIK ectasia. When you put the ring, it flattens down the cone area or ectatic area, where opposite area you do not want to touch. Hence, you put a single ring segment there, and which can give you tremendous outcome. The surgical technique, it's very simple. Femtosecond has made the life very easy. It can be done manually also, but I would rather suggest to use femtosecond laser to be more accurate. The placement can be studied using ASOCT or Pentachem, and further visual rehabilitation can also be achieved using phakic IOL later on, and which can give you very significant improvement in the spherical outcome or spherocylindrical outcome later on. The removal in case of any problem is pretty simple. You just have to put an incision which is again 75% depth. Go in the channel, do not cross the scar tissue there, go towards one of the side, and then just pull out the ring, and that's it. It's pretty simple. So to conclude, intracorneal ring implantation is very safe and effective method to treat moderate to advanced keratoconus, and proper case selection is mandatory. Thank you very much.
Thank you, Dr. Himanshu. That was a wonderful talk, kept deliberately so that our fellows and residents could know stepwise how to go about making it, and you make it all sound so simple. I think we'll take again questions after the other talks. Professor Jain is still, I think, working out how to get his presentation online. And in the meanwhile, I'd request Professor Amit Gupta to tell us about how he would get the best out of the SMILE procedures that he does. Dr. Amit, please, all yours.
You can see my screen, I think.
So you need to go to full screen mode. It's visible though.
Yeah. Well, so I'll be talking about how to get the best out of SMILE surgery. Now, as Dr. Mahipal also showed, over the years, the refractive surgery, it has evolved. From the time we used to put blades to the days of SPK, and then going on to the PRK methods and also the femtosecond laser techniques. However, the flap-based procedures, they can have multiple problems of their own. There are flaps stria, there's a greater incidence of dry eye and surface disease following refractive surgery. You can have avulsed flaps or displaced flaps in these patients, amongst others. So the Vizumax laser by Zeiss, it offers the SMILE procedure. Now, what is SMILE? SMILE is a small incision lenticular extraction. And what it does is it's a little bit more than LASIK. So it's a flapless procedure. It's an all femto procedure. It's a single surgical procedure. And if you look at why it is becoming slowly the new paradigm in refractive surgery, it's because it's an all-in-one solution. It does not need an excimer laser. So, and there are much lesser variables like fluence and other laser calibration things. Less standardization is required, and therefore more consistent results are there. And it has very little influence by the ambient conditions. However, it does have a longer learning curve. So the SMILE procedure was FDA approved in September 2016, and the FDA trial was impressive with 88% of the eyes which achieved 20/20 vision. And so this SMILE procedure is unique, in the sense that there is a curved applanation interface. I think that's a very, very useful addition for the refractive surgeon. So there's a distortion-free applanation. The laser energy here used here is in nanojoules instead of microjoules that it is used for in femto procedures. So what does this curved interface do? It allows us to have corneal suction. Now, this gives us the ability to have a low suction pressure, minimal applanation, minimal IOP rise, and no vision loss during the suction. Now, all these things are very critical to ensure a good visual outcome in our patients. A study carried out on animal eyes, it showed that the mean rise of intraocular pressure was almost 1/3 of that seen with several other lasers used for femtosecond LASIK surgery. Also, these ugly subconjunctival hemorrhages that are fairly common after femto LASIK are not seen with SMILE. Let's take a look at corneal biomechanics. I mean, how does it affect the cornea? So if we look at surface ablation, we know that we remove the epithelium and then we ablate the stroma. And therefore, the rest of the cornea, it gives strength to the cornea after the surgery. In LASIK, a flap is made and the stroma is ablated, and the strength of the cornea lies in the residual stromal bed. In case of SMILE, we preserve the entire stromal layer of the cornea and the lenticule is removed. Now we know that the greatest biomechanical strength in the entire layer is due to the stronger intralamellar collagen bonds, and SMILE results in minimal disruption of these peripheral collagen fibers. So this is a very good meta-analysis of several studies, and what they have shown is that the pooled hedge is it means that how different is it from the normal circumstance. So the effect on corneal biomechanics was comparable to that of a PRK. And because of the attribute of this surgery that this lenticule is removed and angiostoma is preserved, the corneal nerve integrity is preserved. The incision we know is less than 3 millimeters. And what it does is the subbasal nerve plexus is preserved in the cornea, and this leads to less denervation, accelerated neuronal healing, postoperative corneal sensitivity is better, and there's lesser corneal staining or dry eye score in these patients. A meta-analysis of dry eye, which they compared LASIK with SMILE. And what did they find? So many patients ask us, how does it compare dryness of the eye? So at 6-month follow-up, there was no difference in Schirmer's test. The BUT was better in SMILE patients at 1 and 6 months. The OSDI score was better in SMILE patients. There was no difference on the tear osmolarity, and the corneal sensitivity was higher in the SMILE group at both 1 and 6 months. And also the corneal subbasal nerve density was higher in patients who underwent SMILE at 1 month. Also, a publication in ophthalmology, they studied the preoperative with postoperative vision, including contrast sensitivity, total aberrations, higher order aberrations, and they were compared between LASIK and SMILE at 3, 6, and 12 months, and there were no significant differences between both the groups. Several other publications have shown that the refractive and visual outcomes of SMILE are comparable with that of LASIK surgery. The surgical procedure has already been shown by Dr. Mahipal. Essentially, it involves making a lenticule cut, a lenticule side cut, a cap cut, and the cap opening incision. So these are the 4 components on which the Visumax laser is used. And so we first dissect the anterior part of the cornea, and this is followed by the separation of the posterior lenticule from the anterior lenticule. So a few adhesions should be left and then should be moved in the end, so as to enable a good removal of the lenticule. Sometimes all doesn't go as planned, and I think decentration is something which every surgeon should focus on, because this sometimes the nose comes in the way and a young surgeon who's new doesn't realize it. So we should pay special attention, and I think patient counseling is extremely important in these patients to ensure that the patient is cooperating during the procedure. The other dreaded complication, which was also addressed by Dr. Mahipal, is suction loss. And again, it can happen at various stages, and that can bring down the outcome. There are ways to tackle that, but sometimes it can get ugly and complicated. If we do not clean the eye well, if the patient is straining too much, if the surface is allowed to dry, too much of anesthesia is used, there's something known as black spots or dark spots. These mean that there are areas which are not getting separated, and when we go on to dissect the lenticule, we are going to have a major problem on our hands. Many times it leads to a retained lenticule, and that can be a nightmare for the refractive surgeon. The Visumax also has a split view, and this is a very useful tool for us to evaluate whether we have any debris or retained lenticular fragment. So what are the limits of SMILE? It is approved for up to minus 12.5 diopters of spherical equivalent, up to minus 10 diopters of myopia, and 3 diopters of astigmatism. No astigmatism treatment is available, and lower powers are more difficult to treat. If somebody comes to us with minus 1 diopter of myopia, usually that patient is advised some other procedure instead of SMILE, because the lenticule is so thin, sometimes you can end up with some complication. So how can we make smile safer and better? We have to optimize the energy settings. On the left, if you see, I'm struggling with the dissection because the energy was not optimized. So the separation of the lenticule is very difficult. On the right side, we can see it is proceeding very smoothly and I can separate it quite easily. Uh, so how do we optimize the energy? There's a very important sign called gas bubble escape sign. So on the left side, we can see where the arrow is. And as soon as we open the incision, we can see that the stroma has become clearer. And this means that this is the optimum energy. Another way is when we are making the lenticular cut, if the borders are very feathery, it means that the energy is too much and we need to reduce the energy. The white ring sign, so this is the white ring sign we can see as the dissector is moving into the posterior plane. This is very important to see to ensure that the dissection is carried out properly. Differential spot spacing is a very useful thing that we can use. So we can actually decrease the spot spacing from 4.5 to 4, anywhere between this range of 4.2, and this makes a huge difference. Every Visumax machine is different, and we have to customize the parameters according to our own machine and also according to the own surgeon, because every surgeon has their own technique of dissecting the lenticules. To sum up, SMILE provides increased safety, lesser incidence of dry eye, and comparable visual outcomes to LASIK. There is less effect on corneal biomechanical strength compared to LASIK, and a few limitations exist which probably will be addressed in the near future. A lot of things are going on, and there is a significant learning curve, and it's less reliable in higher astigmatism, although there are a couple of publications which indicate similar results to LASIK in patients of high astigmatism. It is still not established for hyperopia. Again, trials are going on. We'll see something coming very soon, I think. The eye tracker technology is missing, but studies have shown that because the patient is fixing so well at a seeing target all the time, that studies have reported similar results even when compared to cyclotorsion software used for LASIK. So there is no customization facility, but again, what do you do with patients with very higher order aberrations or topographic abnormalities? Right now, we would prefer to go in for LASIK techniques for these patients. Besides this, there are several non-refractive uses of SMILE lenticule, like tailored stromal expansion, filling, SMILE extra, and SMILE lenticule for corneal perforation. So it's not just refractive surgery; it helps us in therapeutic corneal surgeries as well. Some of the examples where we use the SMILE lenticules to seal corneal perforation, especially in COVID times, most of these patients, and they have all done quite well. Thank you so much.
So thank you, Dr. Amit, for those, I think, some excellent tips in that talk about somebody who's especially beginning to start out in SMILE, because like you mentioned, it does have a significant learning curve. And I think we'll be discussing more of that at the end of the session. Meanwhile, if Professor Jain is ready, sir, I'll invite you to please present your talk on.
Yes, I'm ready. Okay. So, can you see my screen?
Yes, sir, you're visible and audible both clearly.
All right. So, thank you very much, Dr. Chintan, for giving me this task of presenting phakic IOLs, handling unusual situations. As we all know, we can come across various uncomfortable situations during IOL implantation during surgery as well as after the surgery. A lot of complications can happen in terms of sizing of the ICL, refractive surprises, or tearing of the lens during the surgery, so forth, so forth. So today I will be presenting only two situations because the time is short. So we'll discuss two situations. This is one patient we had operated way back in 2013, and this was the refractive error, and the K readings were this much, and there was cylinder of 1.5 at 120 degree. And this was the rotation chart in the right eye. And so we did the surgery. This is, you can see the IOL is aligned at the proposed axis in the eye, in the right eye. The surgery was done way back in September 2013. And we had a good post-operative volt of around 590 microns. But patient after 2-3 weeks reported with a refractive surprise of plus this much of refraction, though the spherical equivalent was close to zero, but we were quite disturbed by this, why this should happen. So we went back to our chart and cross-checked all the findings. So if you can notice here, the in the refraction, there is a 1.5 at 120 degree. But if you see carefully at the K readings, the steeper axis is at 47. So this refraction is not matching with this K reading. This cylinder should be at 20 degree. So there was a transcription error while noting from the file. In the file, it was 20 degree, but while typing, there was a typographical error in sending the refraction parameters. So instead of 20 degree, it was written 120 degree. So that's why the refractive surprise. So what to do in this situation? So there was a transcription error in typographical error. So what all you will do in such a situation? So we went again the parameters again to the company. So we could either exchange the ICL, or anybody from the panel has any what other solution you have in this case besides exchanging the ICL in this case. And it is a toric ICL with a good volt post-operatively around 600 micro.
I think you can go on the software and see that would a rotation appropriate axis, would that take care of the...
So that
Actually,
is
when the
a...
spherical equivalent is zero,
Yeah.
it would take care of that thing.
Yeah, both of you are right. So at that time, we didn't had that iTrace software where we can check by whether the rotation of the ICL can lead to this thing, but we could have checked it online if possible with the IOL software. So what we did in this case is we just rotated the ICL by 90 degree because the lens was off the mark by 90 because we have wrongly written the axis of the cylinder. So we did a 90 degree this rotation of the IOL in this case. So we rotated it vertically. So nothing much about the surgery. And you can see after rotation, this is the alignment of the IOL, and patient had 6/6 vision, though the volt reduced to around 280 micron. So this is the vertical alignment. So that's how, without replacing the ICL, we could achieve with the rotation if in a toric ICL case. And this is 1 year down the line. So we have followed the patient for quite long now, and patient is doing all right. And this is the second case. This case also had undergone bilateral phakic IOL implantation with poor visual gain in the right eye, with the history of redness as well as pain and rise of pressure in the right eye. And she was started on anti-glaucoma therapy. The vision gain in left eye was good, and there is no previous history of uveitis glaucoma before the surgery. And the past record showed this refraction in both the eyes, and IPCL was implanted in both the eyes, and these were the parameters of the ICL. And when we examine after 2 months, the patient has this 624 visual acuity with this much of refractive error in the right eye, though she was happy with the residual refractive error in the left eye. Without glasses also, she was able to read 6.6 and the pressure was on combination this much. So this is the examination of the left eye. There was a good uh, good vault and there was no complication in the left eye, but in the right eye, if you see, there were peripheral synechiae in this area as well as in this area. The doctor has also done an inferior PI to control the intraocular pressure. There was some pigment dispersion behind the lens on dilatation of pupil, we can see, and the periphery of the chamber was very shallow and the center was quite deep. And so this is a case of poor visual gain following the phakic IOL implantation. And we thought of these situations, it could be again a wrong refractive calculation or inadequate size or a misplaced phakic IOL. So we did all these investigation, including anterior segment OCT, eye trace, and UBM. On OCT, you can see the lens is upside down. The vault is almost zero, and this peripheral part of the IPCL is pushing the RS anteriorly, leading to the peripheral anterior synechiae in this case. Same is shown on the pentagram shine plug imaging. And this is on UBM. Again, you see the lens has been put upside down and the RS is being pushed anteriorly on UBM. And in the left eye, the vault was good enough. And it is as on Shimpling also, and UBM also showed okay thing. And on eye trace of the right eye, you can see some grade of opacity in the lens, 1.5. And the internal imaging of the eye simulation was very poor. It was less than 5. So there it indicates there is some degree of cataract also, and the simulated image in the eye was this much after the correction of refractive error. And so the final diagnosis was this was an inverted phakic IOL. So we plan to reimplant the ICL after taking it out, or in case we damage the lens or otherwise, we also ask for a replacement of the lens from the company with these parameters. Same reflection was used for asking the new lens. And the surgical steps, as you all know, we dilated the pupil on the table and we opened the previous incisions. And first, we try to separate the peripheral anterior synechiae. After that, we just pull out the lens from the posterior chamber by hooking it with the Sinskey hook, deliver it into anterior chamber and take it out with the forceps. It comes out easily. And once we examine this lens IPCL, one of the haptic was already folded upon itself. It didn't straighten, otherwise we would have used the same lens, put it in the eye after reversing it. But the haptic was not straightening. So we used the new IPCL in this case and injected in the eye. And this is how the configuration of IPCL is there, as you all know. And we injected the IPCL in the eye. And uh, just to show the brief video of this, this is the dilatation of the eye. After dilating, we opened the previous incision. They were 2 months old, so they could be easily opened. And then we separate the synechiae which were there in this area and in this area, so that we get not a shallow anterior chamber or the zipping of the angle post-operatively. After that, we displace the lens from the posterior chamber to the anterior chamber, and by using a Lester hook, by hooking in the holes of the IPCL, and this is just displacing the IPCL in the anterior chamber, and once we displaced it by the uh, pulling forceps, we just hold at the haptic optic junction and just pull the lens out. So it comes out easily. And as you can see, this one of the haptic is folded upon itself. By repeated straightening, it didn't straighten out. So we used the new IPCL and injected this new IPCL into the anterior chamber in a proper configuration that you all know how to load and deliver it. So it was injected in the anterior chamber and tucked into the posterior chamber, and the Varion was used to align the torus IPCL, though it is not visible because our this thing is not integrated, though we can see on the screen, but in the recording it doesn't come. So it was properly aligned, and after that on the washing was done, and so that is the end of the surgery. And washing of the, and you can see some opacities in the lens, you can see because the lens was there for almost 2 months touching the crystalline lens. So uh, so this is the post-op picture on day 1. Patient has 6/9 vision, and you can see some pigment dispersion on the anterior lens surface, crystalline lens surface, and pressure was also normal. And we discontinued the Combigan drops. And this you can see after 3 weeks. These are some bleb-like opacities in the anterior subcapsule. We are following up the patient whether they disappear or not. Only the time will tell. So patient had 6/6 partial vision, and on the sham flank images, you can see 320 micron of volt in this case. And eye trace also showed improvement in the quality of vision, and the grade of opacity here now has decreased from 1.5 to 5. And so these are the two unusual situations, though there could be n number of situations where we come across and to deal with the situation, but these are the two important ones where we could deal it in an amicable manner. I have other two patients where actually we had to exchange the ICL because of the sizing issue. But even after changing the size of the ICL to one bigger size, still the wall didn't improve beyond 50 microns. So we tried to do UBM in both those cases, but we couldn't see. Most probably, we think in those cases there was a zonular were lax, or the ICL was not resting in the ciliary sulcus. We really don't know the reason. So in one of the cases, we had to remove the uh, ICL. In one case, patient who had around 50 to 80 micron, already 5 years are gone. So still vision is 6/6 and there is no cataract. I don't have the record of that patient. So we really don't know why, even after putting a 13.2 ICL, still the vault didn't improve. So thank you very much for the patient hearing.
Thank you, sir. And now, because our time is running out, we'll proceed to the next talk, and that is by Dr. Shreyas Ramamurthy. And Dr. Shreyas is a cornea cataract and refractive consultant with the Eye Foundation Coimbatore, and he's done a lot of work on topography, guided basic, and he has a very interesting publication also, which he's done. So we are looking forward to his talk, Shreyas. Please go ahead.
Good evening, everyone. At the outset, I would like to thank the entire Chandigarh Ophthalmic Society and especially Dr. Chintan for this very kind opportunity. I'll just start sharing the screen now. So today I'm going to be talking to you all about contour topographic guided LASIK and what works and what doesn't. So the interest in topography-guided laser ablation has been around for a long time and was primarily being used for irregular corneas. And it's only recently in the last 5 to 8 years that we've started using it for regular corneas. And some of the advantages of topography-guided LASIK is that the measurement itself is far more accurate. The measurement is not affected by the pupil, unlike in wavefront measurements. It is a static measurement. There are more measurement points available, better peripheral data, and most of the higher order aberrations arise from the cornea itself, and having a corneal-based measurements definitely helps. The initial interest in topography-guided LASIK, especially contour LASIK, came about after the publication of this paper for the FDA approval from Doyle-Stuckling's group, which showed excellent results. It was a single-arm study of topo-guided laser treatment in regular corneas, and they showed that almost 40% of patients gained one or more lines in best-corrected visual acuity. They showed that even 30% outperformed glasses and contact lenses, a very high satisfaction rate, and a significant decrease in photic phenomena, visual symptoms, and reading difficulties. But one thing we must bear in mind is that the FDA study, or the paper which we just discussed, had a lot of stringent criteria. They did not allow a difference of more than 5 degrees between the refraction axis and topography axis if the cylinder was greater than 2 diopters. For a smaller cylinder, less than 2 diopters, the difference was what was allowed was only up to 10 degrees. So your subjective refraction and your topographic axis has to match very, very closely for you to go ahead with the treatment that they prescribed. So how is contour treatment performed? Essentially, we have a Placido-based device called the Wavelight Topolizer Vario, which takes in the Placido-based images. And on top of that, the higher order aberration over the clinical refraction is combined together and is transferred wirelessly to the Wavelight EX500 system. And then the ablation profile is modified suitably. But prior to this planning itself, it's extremely important that we have quality images. We compare each of these images and ensure the difference between the images is as low as possible. We also have to ensure that the data captured, there is no extrapolation, and more than 90% of the analyzed area is available for calculation. And this is shown in this particular picture where the 6.5 mm zone, you have a red area. In these cases, the scans have to be repeated either by after using some lubricants or ensuring that the lids are well separated. So this is a typical picture of a wavefront optimized image where you have it perfectly centered over the pupil, a central ablation of 36 micron in this particular patient, in a seemingly normal topography. But with a zero power, this is just the depiction of the higher order aberrations. You can see this is centered over the corneal vertex, and it is not exactly around the pupil itself, and about 10.5 microns of ablation in a relatively seemingly normal cornea. So the final ablation is about this central ablation, which is a combination of wavefront optimized and higher order aberrations. So we looked at comparing the outcomes of contour LASIK, topography guided LASIK, using the criteria which FDA laid down versus wavefront optimized. And we found that while the results were good, they were comparable between both the groups, both in terms of residual spherical equivalent, efficacy, accuracy, changes in lines of CDVA, all were similar. However, there was a lower induction of higher order aberrations in the topography guided groups, especially in coma. This was also shown in another study published from Narayan Netralia, where they showed that wavefront optimized and TCAD comparison, the visual acuity was very similar. Higher order aberrations was a little better in the TCAD group. So contour using this manifest refraction was giving consistent results, but it was not really significantly better than wavefront optimized. So here came the question, if you're doing a topo-guided treatment, would you be better off using the data from the topography itself rather than using only clinical or manifest refraction data? At this time came this paper from John Canelopoulos, where he spoke about topo-modified treatment. And I'll talk a little bit about TMR later, but he compared topo-modified treatment with standard clinical refraction and showed the outcomes of topo-modified treatment were superior. about 66%, 55.6% of patients gained one or more lines of best corrected visual acuity in the TMR group, as opposed to only 27% in the standard refraction group. He also compared it with SMILE in a fairly controversial paper where he showed every conceivable parameter, UDVA, gain of lines, refractive predictability, contrast sensitivity, were all far superior in the TCAT group and clinically and statistically significant as compared to SMILE. So what does TMR actually is? So this is the basic screen where we go into the topography guided treatment. Now you can see here that this is the manifest refraction of the patient, has a sphere minus 1.5 and minus 1.5 cylinder. But the topography itself is suggesting 2.2. So as per TMR, wherever the cylinder of the topography is higher, we go ahead and correct the full cylinder of 2.2 and just make the required adjustment in the refractive spherical equivalent. That is, if I'm increasing this cylindrical correction by 0.75, I reduce the final spherical correction by 0.35. And TMR did not abide by the guidelines of the 5 and 10 degree difference, which I alluded to earlier, but it was they applied it to all kinds of cases across the board, where even the axis difference was much greater than 10 degrees, which is quite often the case which we see in clinical practice. So encouraged by this study, we went ahead and did a study of our own where we compared a contralateral eye study of SMILE versus topography guided LASIK. It was a double-blinded study, and we included patients with only greater than 1.5 diopters of astigmatism. So where one eye SMILE was performed and the other eye, in this particular patient, the left eye was chosen to have the TMR contour LASIK. When you looked at it, this was the basic planning page. And when you looked at it postoperatively, the eye which underwent SMILE on the topography had almost 1.2 diopter residual cylinder, whereas the contour topography was absolutely pristine with almost zero astigmatism on the anterior cornea, as you can see here. We were expecting the patient to be elated with the contour outcome, but on the contrary, we saw that the SMILE eye was unaided 6.6, but the contour eye had a residual cylinder of 0.75. It was not really a residual, it was actually a slight overcorrection, wherein there was a flipping of the axis and the patient from 180 had actually a cylinder at 90 degree. So the SMILE eye, which had a higher residual topographic cylinder, had a better uncorrected visual acuity and the patient was subjectively more happy. Whereas the TMR eye, where the topography was pristine, had a cylindrical error with the flipping of the axis, and subjectively the patient was less happy. Apart from our study, it was also proven in this paper where they showed when they compared primary topography guided LASIK treated as per the topography measured anterior astigmatism or TMR versus manifest refraction, they found that when the difference was more than 20 degree, the outcomes of TMR was quite inferior to that of the manifest refraction outcome. The main reason for this is that this final cylindrical correction has different components. It's not just the anterior corneal astigmatism which you measure on your Placido device. It is also a combination of the anterior corneal astigmatism, the higher order aberrations, especially coma, which could be contributing to the astigmatism, your posterior corneal astigmatism, and your internal astigmatism. In this particular case, as you can see here, this elevated area is almost contributing to 11.5 microns. It's almost a diopter of correction. And this particular elevation, if it is along the axis of the anterior corneal astigmatism, will actually lead to an increase in your refractive cylinder. If it is opposite to your anterior corneal astigmatism, it will lead to a decrease in your subjective cylinder. So position of these higher order aberrations, the location is also extremely important and needs to be analyzed individually. And this, we've started using this Forcides analytical software through which we are analyzing this particular data, wherein you're computing your manifest clinical refraction, you're using the contour measured treatment astigmatisms from the anterior cornea. We also take from the pentacam the anterior and posterior corneal data. Posterior corneal data is fed directly from the pentacam. And you also take the tissue ablation for neutralizing the higher order aberrations measured using the topolizer. So it then draws out vectors for each of these elevations and tries to analyze the effective amount of astigmatic correction of each of these elevations. And then you have a final vector plot of the corneal astigmatism, your total manifest astigmatism, your astigmatism by the higher order aberrations, your posterior corneal astigmatism, and then you have the final output. And this we've started seeing has started giving us superior results and more comparable results. And this was published recently by Dr. Lobanov, who is the chief architect behind this Varsity software. And he's shown that a greater percentage of eyes achieved 20/16 or better as compared to manifest refraction. And also a greater proportion of patients had gain in lines of uncorrected and best corrected visual acuity. We also have a contralateral eye study going on so far, comparing Varsities with Contira using manifest refraction. And unlike the FDA study, we are including patients with a wide difference between the topography measured and the subjective refraction. And we are seeing more superior and consistent results even in this subset. So in conclusion, it's important that you analyze the measured versus subjective refraction. If you're unable to get a proper rationale why a particular measured refraction is higher or lower than the subjective refraction, it is better to stick to your wavefront optimized treatment. And at the end of the day, we must remember that it is the uncorrected visual acuity that the patient is more concerned about than the topographic regularity of his cornea. Thank you so much for your kind attention.
Yeah. So thank you, Dr. Shreyas. I think very important points brought out in that talk, that in our enthusiasm to do topography guided surgery, sometimes we forget what the patient is really looking at and what will be best for him. I will now invite Dr. Hemlata, who's a senior consultant at the Center for Sight in Delhi and a very close personal friend, for her next talk, that is surface ablation, when and how.
Thank you, Dr. Chintan, for having me here. And are you able to see the slides?
Not yet.
Not yet. I think you have to share.
I shared the screen. I'll share once again. Just a second. Can you see it now?
Yes.
Yes, we can. Go to full screen. You need to go to
ma'am, down in the screen. Yes, click that, ma'am.
Is it okay now? Is the full screen visible now?
Yes.
Go ahead.
Okay. Thank you, Dr. Chintan, for having me here. So we all love the cutting edge technology, be it femtolesic or SMILE or Contura, but the surface ablation comes as a savior when we are dealing with the complications associated with these. So today I will be talking about the very basics of surface ablation, the current indications and techniques that I feel every beginner should be well versed with. So PRK got introduced in 1980s, and soon it became very popular because of the ease or simplicity of the doing the procedure, and also because of the cost effectiveness. But in 90s, because of post-operative pain, delayed wound healing, haze, and also because of the introduction of LASIK, it led to the decline in its popularity. In 2004, it again re-emerged as a much better procedure. This time we termed it as advanced surface ablation. That included LASIK, epiLASIK, and PRK with MMC. So today I'll be talking about the current indications and techniques of advanced surface ablation. So when do we do it? So the first and the foremost indication is thin but healthy cornea. Any pachymetry less than 490 microns, the flap-based procedures are not advisable. And when we are dealing with the borderline corneas, you're not sure about the biomechanical strength of the cornea, then again, surface ablation is a much safer procedure. For steep K, any reading above 48 diopters, it in itself is independent risk factor for the development of pictasia. So for steep Ks, again, PRK is the preferred procedure. For the persons who are engaged in contact sports like fighters, boxers, and the military personnel, again, PRK is a much safer procedure. So when we're dealing with the complications of post-refractive surgery, like in this patient, for example, the patient presented to us with a post-LASIK corneal scar. The LASIK surgery was done with microkeratome elsewhere, and the patient had loss of glare with drop in BCVA to 6/9. The refraction was -2 with a -1 cylinder. We did do anterior segment OCT to see the scar, depth of the scar and flap. The scar was involving almost whole extent of the flap flap, and so we had no option other than to amputate the flap. We did that, waited for 3-4 months for the refractive stability, and then performed PRK for this patient. And this is the end result, where there is a minimal scarring and the patient improved to 6/6 vision, and there was a minimal glare left. So then when we are doing enhancement procedure and we encounter lesser residual stromal bed, lifting of the flap is actually not advisable, as it can lead to the reduction in the biomechanical strength of the cornea, and their incidence of ectasia is much higher. So PRK is a much safer procedure when you are dealing with lesser residual stromal bed. Topo-guided PRK has excellent visual outcomes in cases of irregular astigmatism, causes because of post-refractive surgery, keratoconus, post-keratoplasty, or post-RK patients. So here is one such patient where we were doing smile surgery, and we had a suction loss at the 70% posterior lenticular cut. And immediately we converted the procedure into femtoelastic procedure. And there was a little struggle in lifting the femto flap, but still it could be done normally. And to our surprise, on day 1, the patient presented like this with central island irregularity, and there was residual refractive error of 3.5 diopters with drop in BCVA to 20/30. So we did interior segment OCT again to see what is happening, and the flap thickness was 290 microns in the central area. The residual stromal bed was 220 microns. We again waited for 3 to 4 months for the refractive stability, and then proceeded with topo-guided PRK along with cross-linking, as the residual stromal bed was less than 250. So this is the outcome that you can see. There is uniformity of the topography, and the patient's BCVA improved to 20/20 parts with minimal cylinder left. So some of the other indications are anterior basement membrane corneal dystrophy, deep-set eyes, or previous surgery involving the conjunctiva. Now coming on to the technique, there are 4 major steps of the surgery, basic steps: the epithelium removal, then application of the excimer laser, mitomycin C application, followed by BCL. So the step that has evolved the most in the recent years is epithelium removal in a quest to give a smoother stromal bed for ablation. So epithelium can be removed either manually or with the help of alcohol, laser, or microkeratome, or epiclear, or moil brush, etc. So I'll be showing you a video where we use alcohol to remove the epithelium. 8.5 millimeter well is placed on the cornea, filled with the 20% alcohol, and then kept it there for 30 seconds. And then before removing, we soak the alcohol. That loosens the epithelial cells, that we can remove either by using simple Maricel sponge, or we can use the blunt spatula just to clean the epithelium cells from the center. The care must be taken to avoid any spillage onto the conjunctiva that can lead to immense pain in the postoperative period. So you just need to press the well along the cornea, against the cornea, whenever you're applying the alcohol. This is followed by the application of excimer laser, and then mitomycin C application and thorough wash and application of BCL. So mitomycin C is actually an alkylating agent that prevents the subepithelial haze and may reduce the incidence of regression. We use it in a concentration of 0.02%. Duration of the mitomycin C application depends upon the number of diopters that we are going to treat. For up to 3 diopters, we apply for 30 seconds, and then add 10 seconds per diopter thereon. The most important step is to wash the mitomycin thoroughly with using 30 to 40 ml of saline or ringalactate. With alcohol, the main concern is the potential toxicity of the alcohol, as ethanol can produce increase in the inflammatory response that can increase the pain in the postoperative area, postoperative time, and also the increase in the postoperative haze. Now, to avoid the complications associated with alcohol or the problems with the manual debridement, trans-PRK or the laser-induced PRK was introduced. First is two-step procedure where PTK is done to remove the epithelium and PRK for the refractive correction. And later on, Schwind came up with the single-step procedure that was known as trans-PRK, where ablation was done in a continuous manner to ablate the stroma first, followed by the epithelium. So here is how we do trans-epithelial PRK on MEL90 that we have. So first, the laser is applied to remove the epithelium. So it removes the epithelium uniformly, and the healing post removal is like really fast. And this is followed by the excimer laser to correct the refractive error, and rest of the procedure is same with mitomycin C application and then thorough wash of the cornea followed by the BCL application. So if we compare all techniques, all techniques are fairly comparable in terms of pain perception, speed of epithelial closure, or visual recovery, haze formation, and final visual outcome. The post-operative care, standard post-operative care is use of topical antibiotics, low potency steroid that are tapered over a period of 1 month. BCL is removed depending on day 3 to 5, depending on the epithelial healing. Lubricants are given for 3 months, and then we use cyclosporin patients in cyclosporin eye drops in all patients for 2 months. There can be many complications post PRK, but the most peculiar one is reticular stromal haze that is seen in almost like 0.5 to 5% of the patients. And the main associations are high myopia, ablation depth more than 80 microns, vitamin D deficiency, UV exposure, ocular surface disorders, and contact lens intolerance. So recently, Dr. Shetty's team has come up with the PRK Perfect protocol. That is an algorithm for managing the post-PRK haze, where they have emphasized the role of treating ocular surface first before taking the patient up for PRK. And if the haze starts, even then treating the ocular surface with either doxycycline or frequent lubricating eye drops, and also treating the vitamin D deficiency they have suggested. It should be done to treat the post-operative PRK haze. So all in all, surface ablation is a very safe procedure as shown by these 2 recently published studies with a 20-year follow-up on PRK and with no long-term life-threatening complications. So surface ablation stands out as the best treatment modality when we're dealing with thin corneas, retreatments, post-corneal surgeries, and for irregular corneas, topo-guided PRK can be combined with CXL, and as it provides excellent visual outcomes and long-term safety and stability is really good. So surface ablation is definitely here to stay. Thank you all for the kind attention.
Thank you, Dr. Hemlata. I think that was a wonderful presentation. Just one question I have for you. Do you do re-PRK, and how do you plan it? If you have to touch up a patient again after doing a PRK, do you do it?
PRK after PRK?
Yes, if there's a residual refractive error.
See, PRK we are already doing in corneas that are already thin. So there are more chances of haze also if we are doing re-PRK. So I actually don't think that the residual stromal bed will allow us to do re-PRK. Yes, but if you have minor undercorrection, say to the range of 0.75 to -1, and then if we are doing re-PRK, application of mitomycin C again is must. But in my experience, we haven't done ever the repeat PRK for any patient.
Personally, even I don't believe in touching up with the PRK. Perhaps Dr. Mahipal would like to comment on that, sir. Could you give a comment on whether you would like to touch up a patient with a PRK if he has a very minor refractive error depth?
I think the first thing is to look at the reason for a regression, whether it's a haze, and then you have to look at the epithelium. And if there is a haze at that particular time, even just a removal of the, even on a PTK mode and putting mitomycin for a much longer time can give improvement in the refractive error. If there is no other contraindication vis-a-vis, there isn't an excessive haze, there isn't a lot of epithelial hyperplasia or anything like that, under those circumstances, and the residual bed thickness is normal, I would not have any issues in going ahead and doing this retreatment, but with a longer duration of mitomycin C.
Yes,
Because
absolutely.
should there be a contraindication, because there can be a normal regression in any of the refractive procedures, and if there is nothing else that is going wrong, you can, and the parameters are okay, you can go ahead and do that. But you need to identify the reason as to what exactly, and whether there is any excessive haze, epithelial hyperplasia, that you have to take care. Even just these kind of things, you just keep waiting for some particular time, and maybe keep them on steroids, and the haze tends to go, and the refractive error also tends to become better.
Whenever there is haze, actually it leads to hyperopic shift. So if the patient is presenting with the hyperopia, then the haze should be ruled out first.
My second question is that, there's a lot of confusion regarding the post-operative protocol treatment in patients who undergo, PRK. A lot of, I like to give some vitamin C. I don't know, just, a lot of people like to give vitamin A ointments, steroids, how long, low dose steroids, low diphenol. Sometimes we do give it for 6 to 8 weeks. You said cyclosporin in all patients. Is there any standard protocol you would like to suggest to everybody who's listening uh, after the surface ablation?
People used to give long-term steroids only when we were not using mitomycin C. So when we are using mitomycin C, actually the incidence of haze is actually negligible. So we at the center site, we are just using low potency steroids like lotepred, and we are tapering it down over a period of 6 weeks at the max.
Yeah, that's fine.
Okay. I wanted to ask, what is the view of the panel on, like, some people recommend, it's been published in a few studies that, the duration of MMC can be reduced for very low refractive errors. Like there was a publication where you could use it for 10 to 12 seconds. Like I personally, for the low refractive errors, tend to use it only for like 12 to 15 seconds, and seems to work very well with no haze. Of course, in higher refractive errors, one tends to go higher. And some people, even less than 3 diopters, do not use mitomycin C at all. Though personally, I have not done that. So, Dr. Himanshu, your views on that?
Yeah, Chintan, I totally agree with you. Parag Majumdar's group, they had reported that the optimal time was 15 seconds according to them. And again, none of us have any idea about the golden period. What I would look at it, I would look at a risk and benefit ratio of anything, whatever I am doing. So if using mitomycin C poses a higher risk to my patient, I would avoid it, which we know that it's not. So in low refractive error, though earlier in possibly my past life, I would have not used less than 3 diopter refractive error mitomycin C. I do use it now. And I go by per diopter 10 second, but usually 15 second in the low refractive error is something which I use. Having said that, I really don't think anybody is right and wrong here. Whatever works in your hand is fine. Everybody is shooting in dark.
I think mitomycin C is like really safe in low concentrations. So 15 seconds versus 30 seconds is not going to make much difference.
So what they claimed was that that group, that 15 second was optimal. It wasn't required to use more than that. Again, in their population, their ethnicity, their geographic location may be very different from us. So I think what works in our hand, we can still
So
go.
actually, I think there is an unwritten kind of a thing, 10 seconds per diopter. I think most of us are following that.
True.
But you can't really have a clinical this thing, and it's reasonably safe. That's the point. I have not had any specific problem because of the use of mitomycin C.
True.
That's correct. And with time, we are going towards higher and higher refractive errors where we are using mitomycin C. We have used for a longer duration of time, and it has worked out to be safe till now, at least in all of our hands combined.
Actually, Amit, I have become, I'm not very aggressive. My cutoff is 6 diopters.
Yeah, same here.
I don't use surface ablation for a while, because you have these phakic implants and all. And I think sooner than later, the emergence of good trifocal lenses or CRV lenses that have come, worst case scenario, I think we might be going for a relax. if the patient is not suitable for an ICL also. So I would restrict myself to -6 and not beyond that for surface ablation.
I think that's a good message for the audience that I think up to 5 or 6 chapters would be all right. One question for you, Himanshu, is, with the advancements in contact lenses, semi-square lenses and all that, it kills off many patients who would be potential candidates for intacs. Now, where would you place your intervention with intacs? Most of these patients are of the category that they would see well with the specialty contact lenses. How do you differentiate? Listen, I want to go ahead with intacs in this patient and then go ahead with some kind of contact lenses to give patient.
So, Amit, I would be really frank here that my number of intakes usage has come down drastically because of these contact lenses. The amount they spend on intakes can be much more what they can spend for a contact lens and can get a better outcome from the contact lens. So yes, I totally agree with you. If I have to choose only one indication where the intakes can far supersede any other treatment, that would be post-LASIK ectasia. It's very simple that post-LASIK ectasia is localized. The other part of the cornea is still treated and still flat. As soon as you put a contact lens on top of it, it's negating the effect of your flattening which you achieved with your LASIK there, or laser refractive surgery there. Hence, putting a ring actually makes the surface as if you have just done a refractive surgery, and the visual outcomes are tremendous. So asymmetric, such kind of post-LASIK ectasia is my primary indication for intakes. Having said that, low refractive error where your spherical equivalent is low, you still can use intakes. Also, as I showed that you can use intakes later on in the spherical error part, you can put a phakic IOL. But I would rather assess a patient how long I can. On day 0, when I'm seeing a patient, I should have my plan ready that when is the last day I'm going to say bye-bye to this patient and how I'm going to reach there with the financial resources of patient, with the time in my hand, and with the age of the patient. So with that, many things fall in place. But you're absolutely right. These scleral lenses have changed the game in the keratoconus patients.
And what about the use of single rings? Is there a place for them in your practice? Maybe you could take that and then
Of
share.
course, where I always look at the place where I'm placing the ring is steep enough. Based on that, I take a call. Now, opposite side, it's already flat and it's in less than 40s and in 30s. There's no point trying to put a ring there. Yes, we were told that to balance it out, you have to put a ring there. But what happens is your spherical equivalent further goes down. So in such cases, I would put a single ring, and I do agree single rings have a role.
In keratoconus as well, or only post-LASIK ectasia?
Again, same thing. In keratoconus also, if I have the significant flat cornea in the opposite area, I don't mind putting a single ring there.
I think at least in my practice, I think about, I would say about 30% of the patients would be going in for a single ring. So it's not that it's basically you have to work out on the nomograms, and as he's rightly saying, there may be no requirement at all for the second ring. One important thing that I just wish to say is that cross-linking needs to be done for all patients. And the other thing is that I would give a trial to a patient with contact lens before I am subjecting it, so that you get a fair enough evaluation whether the person is contact lens tolerant or not. The ring reduces the asymmetry, and then the BCVA can improve significantly even if you do not have the correction of the refractive error. You may not be able to obviously achieve the full correction of the refractive error, but the person can be much more comfortable with glasses in the post-operative period. The other important thing that you need to consider is that once you have a ring in place, the fitting of a contact lens becomes more difficult, especially of our RGP lens, or if you're looking at this. So those are the couple of things that you have to kind of evaluate pre-operatively as to whether you're wanting to go in for a ring or not. And what Himanshu rightly pointed out, I think there are situations which a lot of people are not doing, where you can actually do the next procedure, which is of a implantable contact lens, and I would not restrict it only to a spherical implantable contact lens. I
Sure,
can,
sure.
yeah,
Of course, totally.
implantable contact lenses post stabilization of the cone, post ring, post cross linking. So there is no harm in giving a good rehabilitation to the patient by doing an implant subsequently.
In fact, the interesting part are now that topo-guided PRKs have again changed the game.
Yeah.
Now it has made the corneas from irregular to regular, and patients are able to tolerate now toric soft lenses also. So again, their cost price goes down. So we are spoiled with choices now, and it's ultimately helping out the patients.
Shreyas, I have a question for you. When we play this game of Jenga, where we keep removing these little blocks, and then suddenly the whole thing collapses. Now we are playing around with so many aberrations, this, that, surface, topoling. So the example you showed, I think something went overboard, and the patient was unhappy, despite meticulous planning and everything. So I think there's so many techniques which are available. They are all giving good results. And Dr. Mahipal, any comments, sir, on what would be your choice of thing, or we have to customize it to every patient? I mean, we have so many patients who are generally happy.
See, actually, it is not something which is new. There is a hype that was created way back in the year 2000, 2001, 2002 about supervision, eagle vision when Zyoptics came in. And all of us were actually struggling to get good results. Actually, what we found out was a wavefront optimized ablation was giving much better results than a wavefront customized ablation. So there are a lot of biomechanics of the cornea that you are not really aware. There could be a one kind of an abrasion that is being compensated by the lens or otherwise, and the milieu. So these are all things. Ultimately, you cannot control everything as is theoretically controlled on the bench. So what has stood in good stead across all across all platforms, I am saying, irrespective of the laser, is a optimized aspheric profile of the ablation that has been done. Similarly, even in SMILE, we are like I am presently involved in a study. There is talk about it that you will have now the lenticule also customized as for the wavefront, but I don't know whether that's going to make any difference. It's just a Q cost, the Q value that you're taking and you're customizing according to that in an aspheric profile. That works very, very well for the patient. And in SMILE procedure, the lenticule being totally aspheric, even if there is a little bit of a decentration, it does not make any difference. But when you are looking at a topo guided, a wavefront guided, the exact matching needs to be done, and the cornea needs to behave the way you want it to behave. So I really don't think that it is really a game changer that is happening. Obviously, it's good to talk and it's good to say certain things as to what it is. And the cyclotorsion compensation is one important thing that, as you rightly pointed out, which is kind of which if done, which I think the next generation of all the lasers are going to have, or if you mark the axis with the ink and then change the bottom of the patient interface and you get good alignment, I think that changes the whole thing dramatically. Alignment is something which is very, very important, and I don't think I am personally in favor. I am not doing. I have topo guided. The Mel system also has topo guided. You have wavefront guided, but we do wavefront optimized in all our cases. I don't know Himanshu or anybody else if you have to say anything, but I think there is a lot of.
Totally agree, sir. I totally agree. I totally agree. Can't agree more there. Interestingly, I think we all have used same TCAT in our like 15 years back, and same thing they reintroduced, gave a Contura name, and that time there were people like I think Jerry Chang or somebody. He used to talk about topo guided for normal, and we used to laugh that time, and now we all have. So I totally agree that not every case I think it works out well. Also, we have to take with pinch of salt when we look at the Western population, where the average age is nearly in their 40s and those things. Now, somebody who undergoes such kind of procedure, and if they take care of the corneal abrasion, well, it may help them in cataract surgery within a few years' time later on. But for us, average age is their 20s and early 20s, and there they still have long time for cataract surgery. So most commonly, it is still wavefront optimized. And as Dr. Maipal said, selected cases, when we do such procedures, they do have a more predictable outcome.
There's another interesting fact. We just completed a thesis and we'll be presenting the results at the forthcoming American Academy. So we say that the topo link LASIK, it ablates less tissue. So what we did was we measured the pachymetry at similar times, pre and post, and you'll be surprised that the amount of tissue ablated. I mean, we go by what the VASCA says. Okay, this is the amount of ablation which is happening. But when we compared the maps, the pentacam map, the pachymetry was almost the same within a micron, the mean width. So that was absolutely an eye opener for us that and we'll be reporting these results, shortly.
Professor Jain has been doing a lot of topo-guided surgeries in virgin corneas, actually. Sir, your thoughts on that?
You are muted. Arun, you're...
Yeah. So we have been doing it for almost 15 years. In fact, we started doing it in virgin eyes even before the this USA trial started. So we presented our results in 2013 ASCRS. First I presented, then Doyle Stelting presented the FDA trial study, and the results were quite similar. And as Shreyas was also presented, we didn't use any nomogram or any of the modification. We just went by refractive reflection of the patient, and also took care that the cylinder at least should match with the corneal cylinder. And we also had around 30 to 35% patient who gained 2 lines more as compared to the we did a contralateral eye study, one eye optimized and other eye topography guided. So it does work, and if you select the cases in a more sort of stringent manner, not that in all cases like Shreya was saying, where the topographic cylinder doesn't match with the refractive cylinder, or it's off the axis by around 15 to 20, the results are not going to be so good. So, but in our study, we did find that the corneal thickness or the ablation was almost around 15 to 20 micron less as compared to the wavefront optimized, as well as the higher order aberrations were little less, though they were not statistically significant. They were more sort of less than as compared to the wavefront optimized. And the MEL software itself says it is akin to sort of what we call wavefront optimized. It doesn't induces new higher order aberration. If you go into details of software of MEL 90, they say it doesn't induces newer aberration, and it reduces the already existing aberration. And the rationale of less tissue cutting is, as we all know, it brings about sort of ablation pattern is like that it brings down the hills and raises the troughs, so that the once smoothing happens, the less tissue is cut per diopter. So it does work. So I have been doing even before FDA trial started.
We've had a very interesting round of discussions, and I would like to thank all the speakers, Dr. Mahipal and Himanshu and Professor Jain and Lata and Shreyas and Chintan also. And we had a fantastic session. I think everybody will benefit from it. Thank you so much for your time. And with that, I think we'll end it. We're already 30 minutes beyond the time. And uh, with that, I think we'll call it a day for now. Thank you so much.
Thank you. Thank you.
Thank you, and hope to
Yeah,
see you all in
thank you
Chandigarh
so
next time.
much. Bye bye.
Yeah, thank you. Bye-bye.
Thank you. Good night, everybody. Thanks.
Good night.
Bye.